Hey, Fabio.
Hey, boss.
I heard you had a patient and you're trying to send him home.
Yeah, it's an MRI negative case. I don't think we can do much, unfortunately.
Actually, maybe sometimes a pet can help. I brought a pet. Maybe we should call our expert back. Oh, thank you.
Yeah.
Hey,
I,
Yeah, welcome.
can pets help
yeah,
us in this situation?
absolutely. Happy to talk. Everyone loves to talk about pets and cats and things
Nice.
like that with radiology, right? We have cat scans and pet scans. Well, pet can absolutely be incredibly helpful in epilepsy, especially MRI negative epilepsy. So I guess I'll start by just giving you a little bit of overview about how PET works.
Mhm.
So PET is basically FDG is a glucose analog, right? And the cell is like, a hungry dog. It'll eat anything that's put in front of it if it looks like food. So it's taken up by the cell because it thinks it's glucose.
Mhm.
And then on the inside, it gets phosphorylated like normal glucose. But then because it lacks an oxygen, it can't actually get metabolized and it's now trapped in the cell. And so basically, it shows where the cell was hungry and willing to eat anything when you inject the tracer. So, and it can't come out of the cell. So basically, it's trapped in the cell. So when you have a seizure, your metabolism initially goes way up, right? I mean, it's just, like cells working out, right? They need some lot of food for all of the discharges that it's having. But then, just like you, when you sprint, you eventually end up, kind of petering out and becoming exhausted and not able to like finish your race if you go too fast. So similarly, in the aftermath of a seizure, it actually has way lower metabolism than the normal brain, right? It's the same way, my husband is a marathon runner. He runs a marathon. He goes home, naps the whole rest of the day. Yeah, so that's basically what happens with the pet that runs a marathon, naps the rest of the day for the brain.
Gotcha.
So increase during a seizure. So why don't we do an ictal pet, right? So the problem is that seizures are unpredictable and can be very short. FDG actually has a really short half-life, only about 1.5 hours.
Mhm.
And you can't really get it from like your local nucleopharmaceutical that we normally get it. You need a cyclotron. So if you run out of PET, it has to be like shipped in from basically special neuro radiopharmaceutical companies. So that's one of the problems is like you if you're sitting there waiting for a seizure, you're running out of PET really quick if it's not happening really soon.
Mhm.
But the more important problem is that it has a huge long uptake, about 30 to 45 minutes, as opposed to SPECT the nucleotide for SPECT, it only is about 45 seconds. So instead of like SPECT, which is like taking a picture and just taking one snapshot,
Mhm.
having a pet is basically like doing a time lapse photograph. So not only are you going to see, the seizure, but you're going to see all the things that happen
Mhm.
after the seizure, including when it has decreased metabolism.
Mhm.
So if we look here at the seizure, it's going up and going down. You can see the uptake period is going to average both the increased metabolism and the decreased metabolism. So it kind of almost averages out. It can be very difficult to actually see any change in the metabolism. So if it's increased during a seizure and that doesn't help us, well, it's decreased between seizures. And so that's where we tend to look with PET. So like I said, it's like a time-lapse photography. You're going to see not just the fight that you tried to take a picture of, but everything that happened before the fight, everything that happened after the fight for like the next 45 minutes. So it's kind of, you can kind of maybe see the fight in there, but you have to differentiate it from all the other stuff that happened, afterwards. So why is there hypometabolism during, the interictal period? And people don't really know.
Mhm.
They think that it might be related to inhibition, right? It's the same way, like if you work out really hard, then your muscles are sore, telling you like, hey, maybe you shouldn't work out like that. They think there might be an inhibitory, like kind of protective process, same way your muscles are sore and won't let you work out again. If you decrease the metabolism, you decrease the chance that a seizure can initiate again.
Mhm.
It is related to seizure frequency. You know, if you have less seizures, you have less hypometabolism in between your seizures. So here you can see a patient that had very profound hypometabolism indirectly, and after seizures they had basically curative surgery that after there was remission, the hypometabolism goes away.
Well, that's interesting. I always thought it was related to, you know, how long the seizures have been going on, but you're saying
That too. So it is related. Beautiful. Thank you for the segue. It's related to the duration of the symptoms, right? So if you have new onset, you have less of a chance of catching the hypometabolism versus if you have more chronic symptoms. Now, always, you know, you do better at finding things when they're in the temporal lobe, and also if you have actually an imaging correlate. So, but again, the longer you've had the seizures, the more positive your MRI are, the more likely you're going to get a positive PET.
And this is really interesting too, Leah, that about half of patients with temporal lobe epilepsy that are MRI negative will have hypometabolism on PET.
Yeah.
Really cool.
Correct. So the thing that we were talking about is that this hypometabolism is not just the seizure focus, but also there's around in the propagation pathways. And again, it's thought to be a protective mechanism, you know, against seizure propagation. If they don't have that much metabolism, that they're less likely to fire and less likely for the seizure to propagate. They think that that's what kind of the brain is doing in response. So as a result, when you look at a PET, the hypometabolic region is not just the seizure focus. It is seizure focus plus the propagation zone. So the mantra for PET, it is not localizing, it is lateralizing. So it'll tell you kind of the general area where it is, but it will not give you the definitive, you know, seizure focus the same way that the SPECT can give you a much closer look at where the seizure is coming from. So one of the really important things that I think is it actually makes it much easier for you to read the imaging. Because, for example, in temporal lobe epilepsy, the hypometabolism is not just the mesial temporal structures, it extends into the lateral neocortex. And sometimes even into like the basal ganglia and the thalamus, not as extensive as the temporal hypometabolism, but it does. And so one of the things is that on PET, it can kind of be difficult. Like, is the mesial temporal structure really down relative to the other side? Well, what I do is I look at the lateral temporal cortex. I actually always, and that's really where I feel confident when I see that lateral neocortical hypometabolism, that really strengthens my belief that, you know, that it's not just, you know, asymmetry, that it's truly the region. So here you can see that hypometabolism, it's not just the mesial temporal structures, it goes all the way around the lateral temporal cortex. And in this patient also, you can see there's some hypometabolism in the thalamus as well.
Have you seen a lot of cases where it lateralizes, but the area that's hypometabolic in temporal lobe epilepsy is outside of temporal lobe altogether, or not particularly?
The only time I've seen the thalamus be hypometabolic, but most of the time it tends to just be the temporal lobe.
Okay.
When do you want to get the timing of the PET? So remember, initially we have increased metabolism, then it goes down and it dips below the level of normal brain, but eventually it actually just comes back to normal brain. So usually if you do it within 24 hours of seizure, you'll still see hypermetabolism. Between 24 and 48, it's kind of intermediate. You may see hyper, you may see hypo, but you want to do it basically at least 48 hours after the seizure to see that really severe hypometabolism. And after about 1 week from the seizure, it can actually start to return to normal. You can have hypometabolism on the other side. But again, what's really going to help you is even the hypometabolism on the contralateral side will not be as severe, and it won't extend to that lateral neocortex. So really, like, I'm not even really looking that carefully at the hippocampus on these and the mesial temporal. I'm looking at the lateral temporal cortex because that's going to be my big differentiator.
Right.
Okay, so how good is it? Well, again, depends on where your lesion is, right? So temporal limb, it always does better in temporal. It can lateralize about 84%, and that's kind of all comers, including those ones that are MRI positive. And you know what your MRI shows, and your MRI being positive makes it much more likely. And it makes sense because what we're seeing on the MRI is damage to the hippocampus. And so it means that you've been having seizures for longer. And therefore that you have more profound metabolic changes. So saying it's MRI positive is to a certain extent in the temporal lobe saying you've been having seizures longer. So do they correlate with outcome? So if you have unilateral temporal hypometabolism, you tend to do well. But if you have bilateral, you tend to not do very well. Or if you have evidence of profound hypometabolism outside of the temporal lobe, you tend not to do well. So it's actually also a prognostic indicator as well. So it tells us a lot about the patient, not just how they're seizing, but the severity of it as well.
You mean here the outcome of epilepsy surgery?
Correct. Yeah. Correct. So how does it compare to SPECT, right? PET is more sensitive just because it's more robust to do clinically. It is incredibly difficult to do ictal SPECT well. But if you do Syscom and you get a good injection, it can be much more helpful in terms of being able to localize. So, and one of the things that I always been stressing is they're all data points. They can be complementary. So here you have a SPECT superimposed with the PET. So you can see here the SPECT is showing that the focus is in the mesial temporal lobe on the left, and you can see that hypometabolism on the right, not just affecting where the SPECT focus is, but going around, as I said, all around that lateral aspect of the temporal lobe as well, showing that it's a dysfunctional network, not just the ictal focus. You can see. You can move it all together. It can help with surgical planning, superimposing the PET, the SPECT, the functional MRI, the DTI. You can do all of that together to really optimize your outcome in these patients.
Well, thanks so much again for doing this. It was really
absolutely. I love these talks. So
this is great.